Hello, everyone. Welcome to our first CCRN review free webinar. We're so excited to be starting this webinar series and be developing this product as a whole. I want to introduce myself a little bit, and then I'll talk a little bit more about the CCRN and exactly what it is. My name is Rebecca. I've been a nurse, an ICU nurse specifically, for about 6 years. I worked primarily in cardiac care, surgical and medical ICUs for the first 4 to 5 years of my career. And then more recently, I've been in a general ICU, which has been great experience to kind of broaden my knowledge base a little bit. What I love is teaching new grad nurses that are new to the ICU or just nurses coming into the ICU for the first time. It's always been something I'm really passionate about. So I'm so excited to be teaching this webinar today, specifically on cardiac care, since that's what I focused on for a long time. So that's a little bit about me. Let's talk about the CCRN in case you're not super familiar with it. So CCRN stands for Critical Care Registered Nurse. It is a certification that you can obtain once you've been in a critical care setting for about a year. It's about 1,700 hours. So if you're working full time, that's about a year. So that's the first requirement, is that year of experience. Then you'll sit for the exam and you'll take 150 questions. Only 125 of those will be counted. The other 25 are just for research. And you need 83 of those questions to be correct to pass. Now, that's actually a pretty low percentage. It's only about 60, 61%. But even with that, the test only has an 81% pass rate. So it's kind of a difficult test. I included what the NCLEX pass rate is here. It's 87%. And we all remember that test and how difficult it was. So the CCRN is considered a difficult exam, which is why Archer Review has come together and decided to make a course for it to help nurses confidently prepare for this test, as well as feel like they're gaining some new knowledge to go and take back into their unit when they are taking care of critical care patients. So what is Archer Review developing for CCRN? We are creating right now free webinars that you're watching here while we continue this product development stage. We are building a 1,000 question Q bank so that you can take practice questions to prepare for this exam. Very, very important. And then we are also working on on-demand video lectures so that you can watch lectures like this one at any time. We are also hoping to offer mentoring, where if you want some one-on-one time with a CCRN certified nurse, you can get that with Archer Review. Something I want to mention is that all of our content and all the questions align with the AACN test plan for the CCRN. The AACN is the organizing board that creates the CCRN, and they release a test plan that lists the concepts that are going to be on the exam, as well as it lists how many questions in each area are going to be tested. So for instance, there's 17% of the test is a cardiac related. Those are cardiac related questions. 15% of the test are respiratory related questions. 20% of the test is shared by endocrine, hematology, GI, renal, integumentary. Those all share 20%. So our Q bank aligns with that. You're going to see more cardiac questions than you do endocrine questions because there's more of them on your CCRN. So you can know that you are taking the right type of questions. And same with our on-demand video lectures. They are going to cover the concepts that are listed on your test plan. So that is a little bit about the CCRN. It's a great certification to obtain. A lot of times your hospital will offer some incentive for that, pay you a little bit more per hour. They might reimburse you for the test. And all of that is great incentive, as well as if you want to go back to school. This is pretty much required if you are interested in nurse practitioner or CRNA. And then again, you really just gain a lot of knowledge, the process of preparing for the test, and that'll just help you be a more confident ICU nurse. So we are going to go ahead and get started here. I'm just going to check and make sure everything's looking okay. And then we will dive into some cardiac content. So we're going to get started right here at the beginning with some cardiovascular anatomy and physiology. Now, I want to just preface here that I am primarily speaking to current ICU nurses. If you joined us and you're still in nursing school but interested in critical care or preparing for your NCLEX, that's awesome. I'm so glad you're here. But just know that some of these concepts that I'll dive in a little bit more into, you might not need to know yet. And then some of the concepts that I kind of breeze over, you might still need to know pretty confidently, but I just want to cater this to current nurses. So let's get started here at the beginning with the heart anatomy, general characteristics. So location and size, we know this. It's underneath the sternum to the left side. It's approximately fist-sized, unless there's something else going on with your patient. It's got three primary layers that I want to talk about. We have the pericardium, which is the outer layer of the heart. Then the myocardium, which is the muscle tissue of the heart. And the endocardium, which is the lining of the chambers of the heart. It's the innermost lining. Now, I want to just point out, we're going to talk about a lot of pathophysiology in these cardiac lectures. So starting here in anatomy, if we can understand anatomy really well, all of that pathophysiology will make so much more sense. So the pericardium has this little space in between it, in between the outer layer and the visceral pericardium layer. And it has a tiny little bit of fluid in it that creates good lubrication to prevent friction as the heart is beating. It's very important. But if too much fluid gets in there, it really restricts the heart's ability to fill with blood as well as pump blood out to the tissues. And that's called tamponade. So that's a problem within our pericardium. The myocardium can have problems when we talk about MI, like myocardial infarction. And this tissue starts to die. And when muscle tissue starts to die, it just doesn't work nearly as well. So we can start to see how learning these basic anatomy features can really relate to our pathophysiology later. Continuing with our basic features, I'm going to go pretty quickly through this because we know it. We've got 4 chambers, 2 atria and 2 ventricles, right and left for each. The ventricles are a higher pressure chamber. They are sending blood out of the heart, whereas the atria are just responsible for sending it with gravity down to the ventricles. So you can see how much thicker this muscle is here. Now we also have heart valves, and heart valves are very, very important. They are the doors that allow for blood flow between chambers and vessels. So first we have atrioventricular valves. These are very appropriately named because they sit between the atria and the ventricle. We have the tricuspid valve on the right and the bicuspid or mitral valve more commonly on the left. They're held in place by these chordae tendineae that attach to papillary muscles at the base of the ventricle. They are open during diastole and closed during systole. Those are our 2 phases of the cardiac cycle. And we're going to dive a little bit deeper into that in the next slide. Next, we have semilunar valves. They are between chambers and blood vessels. So they're between our ventricles here and the vessel that ventricle is pumping blood into. So for the right side, we have the pulmonic valve entering into the pulmonary artery. And for the left side, we have the aortic valve entering into the aorta. They are open during systole and closed during diastole. So let's dive into that little process a little bit more. It's not something I want you to remember, that atrioventricular valves are open during diastole and closed during systole. I don't want you to memorize that piece of information. I want you to learn, why does it make sense that those valves are open and closed at the times that they are? And then when we get to murmurs in a little bit, that will all make so much more sense and you won't have to rely on your memorization. So systole versus diastole. These are our 2 phases of the cardiac cycle. In systole, the heart is ejecting blood. It's squeezing and pumping blood, for the right side, pumping it into the pulmonary artery, and for the left side into the aorta. It is when we are getting that blood ejected out of the heart. Now, that's a very important phase. Just as important is diastole. This is our filling phase. Anytime you hear diastole, I want you to think about filling. And this is when volume is coming from the atria to the ventricles. And that ventricle is getting filled up with blood so that when we make it to systole, it actually has blood there to eject, right? So let's think about valves. Let's start with diastole. If we're filling from the atria to the ventricle, this door between the atria and ventricles needs to be open. It needs to be open so that the ventricle can fill. If it was closed, it would not be able to, right? So we want those valves to be open during diastole. Now, during systole, we need our semilunar valves to be open, because if they're not open, then we would be ejecting blood against a closed valve. So that's how I want you to think through this. These valves have to be open when they're open and have to be closed when they're closed. I don't want you to sit down for your exam and say, oh, it's asking about a systolic murmur. Let me try to remember what I memorized about which valves are open and closed. If you understand it, you can just walk yourself through this information and you'll always get the answer right. Really quickly, before we get into murmurs, I just want to talk about blood flow through the heart. Everything that we're going to talk about today is really dependent on a good, solid knowledge of understanding how the blood flows through the heart. So I'm going to go through it really quickly. If this isn't something you feel very confident about, I would just challenge you to make that your task for today. Try to really get a good confidence on this blood flow through the heart. It will make everything we talk about today make so much more sense. So if this is the one thing that you take away from it that you should have totally nailed down, it's blood flow through the heart. That's what I want you to feel super confident on. So we have deoxygenated blood in our venous system. It enters the heart on the right side of the heart through the superior and the inferior vena cava. Then that blood is pumped out of the right ventricle to the pulmonary artery, where it goes into the lungs to be oxygenated. Oxygenated blood returns to the left atrium through the pulmonary veins. It goes through the mitral valve, into the left ventricle, and out to the aorta to feed the arterial system and all the tissues of our body with oxygenated blood. That, again, if that's the one thing you take away from this that you should feel confident on, that is what I want you to know. So let's talk about some abnormal heart sounds. I didn't include normal heart sounds here, something we probably feel pretty good about, S1 and S2. S1 is the sound of our atrioventricular valves closing, and S2 is the sound of our semilunar valves closing right after systole. So we do have some additional heart sounds that are abnormal. We've got S3 and S4, which are considered gallops. Excuse me. They're low pitched. They're best heard with the bell of the stethoscope over the apical impulse area. So S3 is a ventricular gallop, and it sometimes people refer to it as a Kentucky, because in addition to S1 and S2, that's kind of what it sounds like. And same with S4, they refer to it as Tennessee. That's either going to be helpful for you or not. For me, I don't think so as much, but I included it just in case. The ventricular gallop of S3 is referring to rapid ventricular filling. It's heard in early diastole, so right after S2. S2 signifies the end of systole. And right after S2 is the beginning of diastole. So if that ventricle is filling with blood really, really fast, we're going to hear this gallop right there in the beginning of diastole, right after S2. It can be normal in younger patients or those that are pregnant. If it's not normal and it has a pathologic concern, it is indicative of increased end systolic volume or fluid overload, basically. We can see that in hypertension, MI, heart failure, or any sort of valvular disease. Next, we have S4, which is considered an atrial gallop. This is filling of a non-compliant ventricle after atrial contraction. So it's heard in late diastole. So it's called S4 because it's our last sound, but it's heard right before S1 because late diastole happens right before those atrioventricular valves close and systole begins. When we're filling a non-compliant ventricle, right at the end of diastole, something happens where the atria contract and do what's called an atrial kick. And they're basically just squeezing that last amount of blood into the ventricle to get our filling as high as possible. And if we've got a non-compliant ventricle, meaning a chamber with muscle that is not able to stretch and accommodate for volume very well, it's not going to really like that little atrial kick that comes right at the end before systole. So we are going to hear that in the form of an atrial gallop. This is, again, due to a non-compliant ventricle, usually from cardiomyopathy, valvular disease, myocardial infarction, or hypertension. Now let's talk about murmurs. I've been teasing these a little bit. So these are typically heard in valve disease, septal defect, or various cardiomyopathies. We are talking about here valve regurgitation or stenosis. You can see all of those different examples here. Let's talk about what valve regurgitation and stenosis are first. We do have a structural defects portion of the cardiac module that we'll get to a little bit later in a future webinar. But I want us to feel good about murmurs here in anatomy and physiology. So valve regurgitation is all about when you have what should be a closed valve that is not sufficiently closing. That door is still open just a little bit. And it's allowing blood to backflow into that chamber where we don't want it. Stenosis is a problem of an open valve. It's when we have a valve that's open, but instead of being open fully, it's kind of open like this. And blood cannot get through a stenosed valve as easily. So when we talk about when these types of murmurs are heard, it's just important to know that regurgitation, again, is always about a closed valve, and stenosis is always about an open valve. And then you don't need to memorize this slide, right? Because you know what valves are supposed to be open or closed during which part of the cardiac cycle. So systolic murmurs. What valves are closed during systole? The mitral and tricuspid valves. So if we're hearing a murmur above that area of the heart, it's going to be mitral and tricuspid regurgitation, not stenosis, because we're talking about a closed valve. Now, opposite, our pulmonic and aortic valves are open during systole so that blood can enter the pulmonary artery as well as the aorta. So if we're hearing a murmur during systole over those areas of the heart, we're hearing pulmonic and aortic stenosis. Now, a systolic murmur can also be caused by a ventricular septal defect. That's where we've got a hole here in the septum. And during systole, blood is always going to move from higher pressure to lower pressure, and blood is going to move from this left ventricle into the right ventricle. So we'll hear a VSD during systole. Now, same for diastole. What valves are open and closed during diastole? We know that our mitral and tricuspid valves are open to allow for ventricular filling. So if we have a problem with an open valve during diastole, it's going to be stenosis. If we have a problem with a closed valve during diastole, it's going to be regurgitation, and our pulmonic and aortic valves are closed. They also sound different. Our regurgitation has a high-pitched blowing sound, and our stenosis has a lower-pitched, low grinding sound. So this will just help you further diagnose these murmurs. And when you're asked about which murmur it could be on the CCRN, you can think through this cardiac cycle, think about what valves are open and closed during each phase. No memorization needed, right? Okay, so next, we've made it through the structures of the heart. Let's talk quickly about the conduction system. We have 3 centers of conduction within the heart. First is our SA node, or our sinoatrial node. It's our natural pacemaker, beats at 60 to 100 beats per minute. It controls our atrial conduction, and it comes down and starts to control our AV node. Our AV node beats naturally at 40 to 60 beats per minute, a little bit slower, so it's able to delay the stimulus that it gets from the SA node to allow for more ventricular filling. It's also a backup pacemaker. So if our SA node goes out and no longer works, we will typically see our patient be bradycardic, but they're not usually dead because this AV node is able to take over. Then we have conduction fibers that branch down from the AV node. We've got the bundle of His, bundle branches, Purkinje fibers all the way up here. They beat much slower, 15 to 40 beats per minute. Coronary circulation. We'll also get into this. This is very important when we talk about myocardial infarction, because what we're seeing is blockages in these coronary arteries, right? So coronary arteries, they branch off the aorta. You can see them kind of right there, branching off the aorta, and they are responsible for perfusing the myocardium. So very, very important. We have the right coronary artery that branches off here, and it supplies the entire right side of the heart with oxygenated blood. And then we have the left coronary arteries, which divide pretty quickly into the circumflex artery, which branches around the back, and the left anterior descending artery. Our LAD is the big one. It's our widowmaker because it feeds our left ventricle. If we have a major myocardial infarction when our left anterior descending and we are no longer feeding our left ventricle with oxygenated blood, that ventricle is not going to pump very well. Next, we have coronary veins. They return deoxygenated blood from the myocardium to the right atrium via coronary sinuses, is what they're called. So that's just how that blood is getting returned into circulation. Finally, here, I'm going to go through this pretty quickly because we probably feel pretty good about it. We've got our major vessels. They carry deoxygenated, or I'm sorry, the vena cava carries deoxygenated blood from the body to the heart. We've got two of them that kind of have a junction point here in the right atrium of the superior vena cava and the inferior vena cava. Again, bringing deoxygenated blood to the heart to be oxygenated. Then we have the pulmonary artery branching off of the right ventricle, and this is going to carry deoxygenated blood to the pulmonary system for oxygenation. Pulmonary veins are responsible for bringing that oxygenated blood that's now passed through the lungs back to the left atrium to be taken out to the body. And the aorta is responsible for that. This carries oxygenated blood from the left ventricle out to the body. It's got three branches that sit off the top of it here in the aortic arch. And the first one here is the brachiocephalic, which branches to the right subclavian as well as the right common carotid artery. Then we have our left common carotid artery here and our left subclavian artery here. Then this branches down into the descending aorta, and the first little arteries that come off of the descending aorta are our renal arteries. So our kidneys get fed first here with oxygenated blood. Okay, now we are moving on. We cannot talk about anatomy and physiology of the heart too much without getting into hemodynamics. Hemodynamics are what the heart is really responsible for creating. Our blood pressure, lots of different, our pulmonary artery pressure, central venous pressure, these are all components of hemodynamics that the heart really plays a large role in. The first thing when it comes to heart hemodynamics is cardiac output. We have to have a really good understanding of what this is. This is the amount of blood that the heart pumps per minute. We've got the equation here. Cardiac output is equal to stroke volume times heart rate. And we'll break that down a little bit further as well. But this is just a normal measured value. Normal is 4 to 8 liters per minute. And there's lots of factors that affect our cardiac output. So let's talk about a few of those. We've got preload and afterload, which I do remember learning this in nursing school and thinking, I don't really know if I'll ever understand that concept. It was always just kind of a difficult one, but once it clicks, it really does help a lot of things when it comes to the way we care for our cardiac patients. Makes it all make so much more sense once this makes sense. So hopefully we can get there today. So preload is all about volume. When you hear preload, I want you to think volume. It's the amount of blood returning to the right side of the heart. It's basically the amount of volume that the heart has to work with. Afterload, similar word, but means something different, is all about pressure or resistance. That's what I want you to think about when you hear afterload. This is the pressure in which the left ventricle has to work against in order to push blood out of the heart. If we have high afterload, high resistance, a super tight aorta, it's going to be very difficult for the heart to pump blood into that high pressure vessel, right? So afterload is all about what the heart has to work against, and preload is all about the volume that the heart has to work with. Compliance. This is how easily the muscle expands when filled with blood. So compliance is all about diastole. We're talking all about that filling phase of the cardiac cycle. How easy does that heart respond to more volume? Contractility is all about systole, all about the contraction phase of the cardiac cycle. It's the strength of contraction of the heart muscle. Then we have stroke volume. It's the volume of blood pumped out of the ventricles with each contraction. And it relates to how much volume the ventricle was given and the contractility in which that heart is able to pump that volume out. So stroke volume is affected by a lot of different factors as well. And then finally, we have it listed here again. That all kind of creates cardiac output, which is the amount of blood that pumps through the heart, through the circulatory system in a minute. So let's talk about preload and afterload a little bit more. I love this graphic that we have. It really, I think, shows exactly what we wanted to show. That preload is all about the volume being dumped into the heart and what happens to the ventricular walls in response to that volume, the stretch that they're experiencing. And afterload is all about, okay, now we're trying to get this volume out. What conditions are we pumping this volume into? How hard does this heart have to work to get blood into the pulmonary artery, to get blood into the aorta? And you can see here, these are really, really tight blood vessels and valves here. So this heart is having to work hard. So there's lots of factors that affect preload and afterload. Preload is all about volume. So what would increase preload? Fluid administration, right? If we're giving our patient more fluid, they're naturally going to have an increased preload. Decreasing preload would be from diuretics, for instance. If we're making them pee and make a lot more urine, then they're losing vascular volume. Or maybe it's happening to them or not doing anything to this patient. Maybe they're having hemorrhage or some sort of volume loss, massive vomiting or diarrhea can affect preload. Anything that loses volume will decrease preload. Now, afterload, things that increase afterload would be things like vasoconstriction. Maybe, again, we're doing that to the patient with some pharmacological meds like norepinephrine or epinephrine, which clamps down and vasoconstricts our blood vessels. That leads to an elevated blood pressure. If you've got a patient with hypertension, that means this aorta is going to be a high pressure environment, and this left ventricle is going to have to work really, really hard to get blood into that aorta. Or we can see vascular complications increase afterload. If you've got a pulmonary embolism that's blocking your pulmonary artery, that's high resistance for your right side of the heart. If you have stenosis of either your pulmonic valve or your aortic valve, which we kind of have pictured here, that's going to be really hard for the ventricle to empty blood through that door that's only halfway closed, right? So that all increases afterload, makes the heart have to work a lot harder. What would decrease afterload then? Vasodilation. If we can take a tube from looking like this, where it's really hard to put any blood there, and open it up and dilate that vessel, we're going to make that ventricle have to work a lot less hard to dump blood into that blood vessel. We can do this with pharmacology. We've got vasodilators, or it's important to consider whether your patient had a vascular tone change. Are they in septic shock and very vasodilated out? That could reduce our afterload. So let's just put this all together. We've got cardiac output, which is stroke volume times heart rate. It's a pretty easy equation, which is nice. We've got an example here of 50 milliliters, which is a pretty normal stroke volume, times 92 of heart rate. That would equal 4,600 milliliters or 4.6 liters. So what affects that stroke volume part of this equation? Obviously, preload. We're talking about stroke volume, the amount of blood that's ejected per contraction. That requires volume, and preload is where we get our volume. If we're seeing high volume, we're going to increase our stroke volume. If we're seeing low volume, we're going to decrease our stroke volume. Afterload, again, that resistance the heart has to work against. If we're seeing high resistance, what do we think that would do to our stroke volume? Decrease it, right? Because that heart is not going to be able to pump as much blood out if it's facing all that resistance. If we're seeing low resistance and we've got a wide open tube, that's going to increase our stroke volume. Now, contractility, how hard the muscle is squeezing to empty the chamber. That also plays a role in stroke volume, right? If you've got a really boggy, useless muscle, it could have all the volume and it could have the right amount of afterload, all of that's fine, but it's a poor muscle. So it's not going to be able to create a great stroke volume. All of these factors can coexist. You can have reduced preload and poor contractility, but maybe you've got low resistance, so that theoretically should increase your stroke volume. So you can have all these multiple factors, which makes cardiac medicine kind of complicated, but it's very fun in the way of you can address all of these different things and see if you can get your patient a little bit better. So we've talked about this first half of the equation, the stroke volume side. Let's talk about heart rate a little bit. How is heart rate regulated? First of all, we've got autonomic nervous system control. The functions that the autonomic nervous system can affect are automaticity of our cardiac cells, contractility, and chronotropy. So the autonomic nervous system has two different sides to it, and one of them is always in control. We have the parasympathetic nervous system and the sympathetic nervous system. The parasympathetic nervous system is going to reduce these functions that we've just listed during rest. It's when your patient is just chilling, when you're just chilling, you're on the couch, you're not running a marathon outside, you're not running from a bear. All these, your heart's not having to squeeze very hard. Your heart rate's nice at a resting heart rate. Your cardiac cells aren't super automatic because they don't need to be. You're in rest, right? Now, as soon as you're in a time of stress, the sympathetic nervous system is going to kickstart, and we're going to see an increased function in all of these different functions. So we're going to have increased contractility because your heart and your body is stressed. And this nervous system is telling your heart, hey, kick into gear. We've got some things to do. We're going to see increased chronotropy, a higher heart rate. So that is a main way that our heart rate is controlled. Now, in addition to that, we have a lot of intrinsic receptors that help tell the body, hey, I think we need to lower our heart rate, or I think we need a higher heart rate. So first, we've got baroreceptors. They sense pressure in the aorta and the carotid sinuses. They're sensitive to wall stretch. So if we see an increased pressure in the aorta or the carotid sinuses, they're going to tell the heart, hey, slow down. I've got too much pressure here, and I need you to reduce that cardiac output. So if we can lower our heart rate, theoretically, we'll lower our cardiac output and lower blood pressure. It'll do the same thing. If it's sensing decreased pressure, it's going to say, hey, I need more blood. Let's increase our heart rate. That makes a lot of sense. It's all compensatory. Then we have chemoreceptors that are actually sensing oxygen and carbon dioxide tension, which is a respiratory thing, right? Well, if these chemoreceptors sense that there's low oxygen in the blood or too much carbon dioxide in the blood, they can say, hey, heart, can you really low oxygen in the blood? Hey, heart, can you start beating more so that I know we've only got 60% saturation here with oxygen, let's say. Let's just send more blood then to the tissues because I'm not sending really good oxygenated blood. So let's just send more of it so that our tissues have a chance at getting some oxygen. Again, it's another compensation here for pulmonary changes. And then finally, we have natriuretic peptide system. This includes ANP and BNP that are secreted in response to chamber stretch. So these are sitting within the heart. When there's atrial stretch sensed, atrial natriuretic peptide is released. And when there's ventricular stretch sensed, brain or B-type natriuretic peptide is released. And the goal is to reduce blood pressure or afterload. They're basically sensing that that heart is getting bigger and bigger. That muscle is having to stretch in response to more volume, typically from an increased afterload situation. That left ventricle, for instance, cannot eject all the volume that it wants to into the aorta. So it's going to start building up in volume and it's going to stretch in response to that. So then this system will kick in and it's going to inhibit the sympathetic nervous system, which is all increased during stress. Typically our blood pressure is increased with our sympathetic nervous system, which increases our afterload. So we're going to turn that off and say, hey, I need less resistance. Let's inhibit that SNS, cause some vasodilation. We're going to inhibit our renin-angiotensin-aldosterone system, which is all about increasing blood pressure. It does that a couple ways. It starts eliminating water loss from our kidneys and vasoconstricting. So if we want to lower BP and afterload, we need to stop that renin-angiotensin-aldosterone system and cause vasodilation and water loss to lower blood pressure. Now, some other regulatory receptors that we care about quite a bit in critical care are our adrenergic receptors. We have alpha adrenergic receptors and beta adrenergic receptors. And a lot of our pharmacology that we use in critical care acts on these receptors. So starting here with alpha, we have alpha 1 and 2. Typically, the pharmacology that we use is acting mostly on alpha 1, but honestly, they both cause vasoconstriction. So that's all about increasing blood pressure. We're trying to increase perfusion to our tissues by vasoconstricting our blood vessels. The way I remember that alpha adrenergic receptors are about blood vessels, and when we get to beta, it's about the heart, is the A kind of to me looks like a little fish. And I don't know if that'll stick for anyone, but to me it looks like a fish. And I just think of a fish swimming in a river. And a river looks a lot more like a blood vessel than it does a heart. So I remember that alpha adrenergic receptors are talking about blood vessel, our vascular tone, vasoconstriction. And when we get over to our beta receptors, we've got beta 1 and beta 2. The one we care about here in this lecture is beta 1. It's found in the heart, and that's what it's going to act on. Beta 2 is found in the lungs and causes bronchodilation. Albuterol is a beta 2 agonist. So that is where we're concerned about beta 2. In this lecture, we care about beta 1. Stimulation of beta 1 is going to increase heart rate, which leads to chronotropy, and increased contractility, which is inotropy. The way I differentiate beta 1 versus beta 2, there's one heart and two lungs. That's how I remember that, and it seems to work pretty well for me. So that's how you can kind of keep these differentiated, especially when we get into pharmacology and we're talking about the difference between norepinephrine and epinephrine, for instance. Norepinephrine is going to act a lot more on alpha adrenergic receptors and just a little bit on beta. It still does a little bit. Whereas epi is going to be mostly acting on beta 1 and a little bit of alpha, which could help you choose which drug is appropriate for your hypotensive patient. The symptoms can look the same, but when you think about the causes, oh, does my heart need more help, or is this a vasodilation problem and I just need to vasoconstrict the blood vessels a little bit? Relating to this and all these hemodynamics, the CCRN does care about the pulmonary artery catheter. There's another certification out there, the cardiac intensive care certification that nurses can obtain if they're specializing in cardiac care. So it's not going to deep dive a ton into the pulmonary artery catheter, because that's mostly found in those cardiac specific units, but it is going to talk about it a little bit. And for that reason, I want to make sure we touch on it here. So the pulmonary artery catheter is a catheter that's inserted through a central vein, typically an internal jugular vein, could also be a subclavian. And it's thread down into the heart through the right atrium, right ventricle, and then sits in the pulmonary artery. And we use it to monitor heart pressures, like the pulmonary artery pressure, obviously. We can also gauge our central venous pressure, which is right here in the right atrium, and other heart pressures like cardiac output. We can just get a lot, I mean, so many measurements from this line. And it really helps us fine tune, again, the pharmacology typically that we're using for a patient. We can really see, are we helping our cardiac output with this drug, or do we need to switch to something else? Because we've got a monitoring device looking at that. We can also do mixed venous blood gas sampling from this line, which is a blood draw from the pulmonary artery, which basically says how much oxygen is left in the blood right before it's about to be oxygenated. And it can give us insight into, is our cardiac output not sufficient for perfusion? Is our patient really, really sick and drawing a lot of oxygen out of the blood? We can transvenously pace through this line, and we use it for assessment of heart failure, cardiogenic shock, etc. It's a really great hemodynamic monitoring line. I've got a little bit on insertion here because it will remind me to mention the big safety thing with this line. When inserting this line, the provider is going to be sterile inserting the line, and he will instruct the bedside nurse to inflate the balloon that sits at the end of this line so that it is able to float from the right atrium into the pulmonary artery following blood flow. And I want to use that again this time here to mention it is the nurse's responsibility to remember to deflate that balloon once the line is in the proper place. And sometimes we use the balloon to get a certain measurement called the pulmonary artery occlusive pressure that I'll talk about in a minute. And so anytime we're doing that measurement as well, it's very, very important to make sure that this balloon does not remain inflated. My first unit I ever worked on was a cardiac surgery ICU. And we had all these crazy rules about wedging the pulmonary artery catheters. And it was because 20 years before I started working there, a nurse had left a balloon inflated, and that patient ended up dying because it cut all blood flow to their lungs. I mean, it's really quite detrimental. So I've never forgotten that and how dangerous these lines really can be. So in case a safety question pops up on the CCRN for that, or you're taking care of a patient with this line in, that is really, really important. So let's talk about what this line tells us. It tells us quite a few things. So first of all, it tells us the central venous pressure. This is the pressure created on the right side of the heart. It's our preload number for that right side. How much volume is being dumped into the heart on the right side? Normal is 2 to 5. This is pretty patient dependent. So you'll talk about this value with your provider and kind of establish a goal for your patient that is specific to them. Next, we have our pulmonary artery occlusion pressure. This is also known as your wedge pressure. This is when we inflate that balloon. It occludes the pulmonary artery when we do that, and it's able to see what's going on the left side of the heart and give us a number for the amount of volume sitting in the left atrium. That's what this LAP means, left atrial pressure. So this is all reflecting the volume on the left side of the heart, or the preload for the left side of the heart. Then we have pulmonary artery pressure, obviously. This is a pulsatile pressure. So we're going to see a systolic and a systolic pressure and a diastolic pressure. The way I remember the normal value for pulmonary artery pressure is quarters over dimes. You can see here that systole is 20 to 30, so quarters worth 25 cents. And our diastolic pressure is 5 to 10, and a dime is 10 cents. So that's how I remember the normal value for a pulmonary artery pressure. Next, we have cardiac output and cardiac index, which takes into account body surface area. It's a really good way to measure cardiac output. Someone who's 5 feet tall and 90 pounds does not need the same cardiac output as someone who's 6'5" and 300 pounds. And cardiac output does not take that into account, this 4 to 8 liters, but cardiac index does. And this is the amount of blood. We know what cardiac output is, right? It's the amount of blood pumped out by the ventricle over 1 minute, and we can measure that value directly with this line. Next, we have stroke volume, which we've talked a lot about. This is the amount of blood ejected by the ventricle with each heartbeat. 60 to 70 can be a little bit, that's a really tight range for normal. So in practice, you might see it a little bit wider. But this line can measure that. Systemic vascular resistance, it can give us a number for the mean pressure that the left ventricle is pushing against systemically. That's always talking about all the blood vessels that are not in the heart. And then pulmonary vascular resistance, the mean pressure in the pulmonary vascular space. So pressure interpretation, the ones I kind of want you to remember, we've got preload indicators. We talked about them a little bit. Our CVP is the volume being dumped into the right side of the heart. So that's our right-sided preload. Then we've got our pulmonary artery occlusion pressure. That's the volume sitting in the left side of the heart. That's our left-sided preload. We have afterload indicators. A pulmonary artery pressure or that pulmonary vascular resistance gives us the afterload for the right side of the heart. And our systemic vascular resistance, or really our systemic blood pressure, so just your normal blood pressure, can give us our afterload indicator for the left side. There's another number I didn't mention on the previous slides, this left cardiac work index. It's a calculated number, so it's using some of the measurements that the line gets to calculate this work index, and it's depicting the amount of work the left ventricle does each minute in order to eject blood. And normal is 3.4 to 4.2. Cardiac output and stroke volume depend on all of these factors. Just to point that out again, it depends on volume, resistance, and contractility. Okay, so next we're going to get into acute heart failure. And we've got about 17 minutes left. So I'm going to start to talk about the different types of heart failure. We might not get into all the treatment, but I think if we get to a good stopping point after discussing the various types, we'll feel pretty good about that. So left-sided heart failure. Again, I just want to plug knowing the blood flow through the heart. I don't think it's super possible to understand left versus right-sided heart failure, systolic versus diastolic heart failure, if you don't feel pretty good about blood flow through the heart. So let's talk about the pathophysiology of left-sided heart failure. The primary cause of left-sided heart failure is hypertension. That is equivalent to a high afterload setting. If we think about, there's plenty of patients out there who have hypertension and don't even know it. And they go years and years and years with this high blood pressure. And their left ventricle has to overcome that high pressure with every single heartbeat. And eventually that left ventricle is not going to be able to continue to do that. That left ventricle is going to fail and a backup of blood flow is going to begin. So if we're backing up with blood flow, we're going to go from the left ventricle to the left atrium and into the pulmonary system. That's going to lead to pulmonary congestion or pulmonary edema. It's cardiogenic pulmonary edema. We've got fluid on the lungs. Now, as this progresses, we'll talk about this progression here. As this progresses, if we've got lots of fluid on the lungs, lots of fluid in the vascular space of that lung tissue, that's going to increase our pulmonary vasculature pressure. Now, what could that cause? That leads to high afterload for our right side. So left-sided heart failure can quickly become right-sided heart failure as that right ventricle now has to push against high afterload in the pulmonary system. Signs and symptoms. So these top three here relate to that backup of blood flow, that pulmonary edema. We're going to see tachypnea as gas exchange is not nearly as good or efficient if there's fluid in the alveoli. We'll hear crackles in the lung bases. That volume is typically bilaterally dependent. So it's going to be in the lower areas of the lungs, the bases. So we'll hear crackles there. We'll have hemoptysis, which is pink tinged sputum or bloody sputum, as when that volume from the capillary bed enters the alveoli, it'll bring some blood with it. It's not just pure fluid. And then these last two are all evidence of a reduced cardiac output that we're seeing with left-sided heart failure. We're seeing fatigue and exercise intolerance and reduced peripheral perfusion because that left ventricle is not doing a great job of supplying the body with an adequate cardiac output. Now let's talk about right-sided heart failure. We said that left-sided heart failure could lead to right-sided heart failure, and that is the typical cause. Other causes for right-sided heart failure are anything that increases that afterload for the right side. So we could see pulmonary embolism leading to right-sided heart failure, especially acutely, maybe not chronically, and pulmonary hypertension could lead to right-sided heart failure. Again, think increased afterload. That ventricle, that muscle can only overcome that resistance for so long, it's going to begin to fail. What signs and symptoms are we going to see for right-sided heart failure? It all relates to where that backup of flow goes. So with right-sided heart failure, the lungs are ahead of it. So we're not going to see lung symptoms with it. We're going to see backup of blood flow in the venous system symptoms. So we've got peripheral edema. Blood and fluid is going to begin to pool specifically in our lower extremities. Jugular venous distension. We've got engorged veins, right? They're full of volume because there's all this backup of blood flow. Hepatomegaly, an enlarged liver from that vascular space being engorged with volume. And again, these relate a lot to the reduced cardiac output that you'll see, this weakness, loss of appetite. Weight gain is all fluid weight gain because they're retaining all this fluid. The kidneys are typically not being perfused as well in heart failure either, so they're not making enough urine and will retain fluid for that reason as well. Next, let's talk about systolic versus diastolic heart failure. This one gets a little bit tricky because the signs and symptoms between them are very, very similar. And really the only way to differentiate them is by completing an echocardiogram where we can get an ejection fraction value. EF, or ejection fraction, normal is 50 to 70%. And all that means is when the heart squeezes, let's say the atria drops in 100 mLs into the left ventricle. And then when the left ventricle squeezes and ejects blood out into the aorta, it's able to eject 50 mLs. That means it ejected 50 mLs out of 100 mLs. That's a 50% ejection fraction, right? And that's normal. That's great. In systolic heart failure, that muscle is weak and it's not going to be able to eject all the volume that it's being given. So we're seeing reduced contractility during systole leading to that reduced ejection fraction. The most common cause is coronary artery disease. Coronary arteries are feeding that muscle tissue with oxygenated blood. If there's any sort of injury there, that muscle's not going to squeeze as well. Signs and symptoms are very similar to left and right-sided heart failure, but we've got that evidence of reduced ejection fraction. So we know that it's a failure during the systolic phase of the cardiac cycle. We're going to see dyspnea, exercise intolerance, and fluid overload as that backup of blood flow exists. This is known as heart failure with reduced ejection fraction. And it'll look like this when you see it in a chart if a doctor writes it in a note, little r to say reduced ejection fraction. Now, diastolic heart failure is a little bit different. Here, we have an abnormal heart muscle that leads to insufficient filling during diastole. So it's not a problem with how that heart muscle is ejecting. It's more a problem with how much volume the ventricle has to eject to begin with. So we are potentially going to see, and yeah, we will see a preserved or sufficient ejection fraction. But the cardiac output is still going to be reduced due to ventricular volume from impaired filling. And we'll just walk through this with an example again. So instead of that ventricle being filled with 100 cc's, like we used in the last example, we've got impaired filling. So let's say it's only filled with 30 cc's. And then it's able to eject maybe a really good portion of that volume. Maybe it ejects 20 cc's out of that 30. That means our ejection fraction is great. It's like 67%. That's beautiful. But it's still only ejecting 20 cc's. Is that going to make a sufficient stroke volume to have a sufficient cardiac output? No. So we'll have symptoms of reduced cardiac output. But when they do an echocardiogram and they look at the ejection fraction, it'll look like 67%, which is awesome. So that's how we can differentiate and know, oh, this is a systole problem. This muscle's not contracting well because our EF is reduced, or, oh, our ventricle's not filling well. This is a diastole problem. So that is all known as heart failure with preserved ejection fraction. And when you see it in a note, it'll have that little p, and they're saying preserved. And signs and symptoms wise, it's very, very similar to systolic heart failure because we're seeing a reduced cardiac output. And the signs and symptoms of that are the same. So differentiation is all done with echocardiogram, obtaining an ejection fraction. Let's talk a little bit about heart failure exacerbation, and then I'll stop here. So we can have acute heart failure and chronic heart failure. Acute is sudden onset, and our body is not, or the patient's body has not learned how to compensate for that heart failure yet because it's happening so acutely. Whereas chronic heart failure will develop over time, it worsens over time, and the body can start to kind of compensate for it. Now, exacerbations, this is what we're seeing in the ICU most times. Most heart failure clients in the ICU do have chronic heart failure, and it's exacerbated by some other event. So maybe they got an infection, maybe they're having worsening coronary artery disease that sends their heart failure over the edge. Severe fluid overload status, that heart is not going to respond well to fluid overload. Really increases that workload way too much. With those clients with these exacerbations, we're going to see pulmonary and hemodynamic impacts. Pulmonary wise, we're going to see fluid overload that leads to hypoxia. This will be characterized by dyspnea and feelings of suffocation as that client now feels like they're drowning. This client or this patient is going to need positive pressure ventilation support. Applying oxygen is typically not enough for these patients. Their lungs are filled with fluid, so gas exchange cannot occur effectively no matter how much oxygen we give them. We need positive pressure to enter their airways and push through that fluid to allow for gas exchange to occur. Now, hemodynamically, we're going to see this severely reduced cardiac output that in the exacerbated heart failure that leads to severe hypotension. Severe ejection fraction increases risk. Severe ejection fraction reduction increases the risk for ventricular dysrhythmias. So not only do we need to fix our ejection fraction for our patient to have good cardiac output, adequate perfusion, it also really does increase this risk for ventricular dysrhythmias, which can be lethal. So I'm going to stop there for heart failure, and just see if there's any questions we can answer. And we will pick up where we left off. Next week, we've got another webinar, Cardiovascular Part 2, where we're hoping to cover a lot more content in addition to what we heard today. We'll finish up heart failure, talk about some cardiomyopathies, structural defects, get into EKGs a little bit. We would love for you to join us for that. It will be same time next week, next Tuesday. Here is the QR code for it here. So we'd love for you to sign up for that. Okay, it looks like we don't have too many questions. Oh, I see one here. When will the CCRN review be available on Archer? That's a great question. So like I said, for now, in the coming weeks, kind of through the end of the year, we're going to focus on these free webinars. And then we will start releasing products in the new year. That will be with the question bank, which might come up a little bit earlier. But with our on-demand videos, all of that will be coming in the new year. EKGs, and then I've got a question here. Any chance you will go over reading EKGs to aid in helping with all things heart and the patient's overall health goals? Yes, we have a whole little submodule devoted to EKGs where we're breaking down pretty much every common arrhythmia. So we'll go through atrial fibrillation, atrial flutter, junctional rhythms, which I know can be kind of confusing. All of the heart blocks will be broken down in that webinar as well. We're hoping to get to that next week. So if you are able to join the webinar next week, that is what I'm hoping to cover. I know that that is something that nurses can be nurses for many, many years, and EKGs sometimes just are not going to click. And for me, it took quite some time too. And it's something I still kind of try to hone very often, especially when all these patients, they're not all going to look like textbook AFib or textbook junctional, right? So we'll talk through all of that. To aid in helping with all things heart. Yeah. So yeah, that's definitely a goal for next week. And then following our cardiovascular webinars, we're going to try to do one again like every week. And after the cardiac one, we'll switch to respiratory and dive into that. That's the next largest portion on the CCRN. So I said that 17% of the questions are cardiac, 15% of the questions are respiratory. So it's another major section for the CCRN, mainly because no matter what type of ICU you work in, cardiac and respiratory are always going to come up. They're part of our ABCs, right? So it's very, very important that we have a good, solid understanding of these systems. Okay. Will I be able to listen to this recording again? I'm going to have a co-host answer that. I'm pretty sure, but they know more about the tech side things than I do. So I might let them hop onto that. It stays on Facebook. Thank you, Rachel. So yes, you can view it on Facebook. I know we covered a lot of information today, so I totally understand if this is something that you need to go and look over again. I really wanted to pack a lot into this hour. And this is just really important stuff. So if there was something confusing during this lecture, I totally get it. Definitely feel free to go back and listen again. Hop on next week, see if any of those questions maybe get answered then. But other than that, if there's no other questions, we might go ahead and close out here. Give it just a couple seconds. We're on Facebook. It'll be on the Archer Nursing, Archer NCLEX Facebook page. If you want to search that on Facebook, it should come up pretty fast. And you're welcome. This was so fun. I love talking about this stuff. And our other Rachel said that she thinks it will also be on our YouTube channel. So that's another place you can search for Archer there. Okay, everyone, with that, I'll go ahead and close us here. Thank you so much for joining. This was a lot of fun for me. I hope you learned something new. And then would you be able to do quiz questions? Yeah, I think in future webinars, I'm going to add those in for sure. I know that those are super helpful, and we've got people really working hard on those questions. So they're looking really good for you guys. So thank you guys so much. We'll see you in the next one. All right, bye-bye.